everyone. Good morning. First of all, I would like to thank Dr. Tariq and the organizing committee for giving me an opportunity to speak in the first Pediatric Neurodisability Conference. It's my pleasure and an honor to be the first speaker. So today, my topic is to give you a brief overview of cerebral palsy, and it will include definition, prevalence, classification, etiology, diagnosis, associated comorbidities, and their surveillance. Cerebral palsy is not a new disease. Its first description was written by Mr. William John Little, who was an English orthopedic surgeon in 1860. This famous definition of cerebral palsy was brought in April 2006 by the surveillance of cerebral palsies in Europe. According to this definition, cerebral palsy is a group of permanent disorders of development of movement and posture causing activity limitation that are attributed to non-progressive disturbances that occurred in developing fetal or infant brain. The motor disorder of CP are often associated with the vast majority of disturbances, which include disturbances of sensation, perception, cognition, communication, behavior, epilepsy, and some musculoskeletal problems. Overall prevalence of cerebral palsy is about 2 to 3 per 1,000 live births. However, this prevalence rate increases to about 40 to 100 per 1,000 live births among babies who are born preterm or of very low birth weight. Data from the Northern Ireland Cerebral Palsy Registry revealed that half of the children with CP are born less than 2.5 kilograms. I searched the literature about the current prevalence rate globally and also its trend. And this publication I found in Developmental Medicine and Child Neurology. It's a systemic analysis to determine the trends and current estimates in regional and global prevalence of CP. And when I looked at the results, I found that 41 regions from 27 countries across 5 continents were represented. Birth prevalence for pre- and perinatal CP in regions from high-income countries in Europe and Australia was about 1.51 per 1,000 live births. However, when the post-neonatal CP was included, it was 1.6 per 1,000 live births. From the very limited data which was available from the low and middle class, middle income countries, prevalence of pre- and perinatal CP was as high as 3.4 per 1,000 live births. So what it shows that in high income countries, the trend of cerebral palsy prevalence is decreasing. However, in low to middle income countries, it is still the same. And that we very well know is attributed to the increased and healthcare system providing the mothers and the postnatal care to the babies in higher income countries, while in the lower income countries, it is still the healthcare system is not so good. Cerebral palsy management involved a very high cost, a very high burden on any health system. And this is one study which was published in 2009, and it shows that the lifetime cost of the CP was about 860,000 euros in men and about 800,000 in women, which is a very high cost. And there is another study which was published from United States, and this was about they estimated the medical expenditures attributed to CP and among the children who were enrolled with the Medicaid and stratified by the presence of co-occurring intellectual disability related to the children without CP or intellectual disability. And they found that the medical costs for children with CP alone were 10 times higher than for the children without CP or intellectual disability. 16,000 versus 1,600. And medical costs for the children who had both cerebral palsy and intellectual disability was about 26 times higher, 43,000 versus 1,600. So it's a high difference. CDC has estimated the lifetime cost to care for CP was nearly $1 million per whole life of the person. And this figure is back in 2003. So we can imagine in now, 20 years later, what will be the cost? So when such a high cost is involved, in the management of the patients with cerebral palsy, our primary aim is to prevent it. Primary prevention should be aimed, and strategies should be formed to decrease the prevalence and incidence of cerebral palsy. So to do that, we should be aware of the causes or etiology of the cerebral palsy. Cerebral palsy causes can be divided into prenatal, perinatal, and postnatal. Prenatal causes include developmental malformations of the brain. And we know that and the neuroradiological studies performed have shown that about 7 to 11% of the cases of cerebral palsy have underlying congenital malformations. Other causes include congenital infections, placental insufficiency, vascular causes giving rise to antenatal stroke, maternal factors, and maternal factors include age of the mother, very young mother, and very old mothers have high risk of giving birth to children who may develop cerebral palsy. Then the mothers who have chronic health conditions, who are living in poor socioeconomic status or are addicted to illicit drugs, they are chain smokers, they are alcoholics, they have all these factors increases the prevalence rate in the babies born to these mothers. This one study showed the contribution of socioeconomic status on the prevalence of CP, and the result of this study shows that 12 studies were included in the systemic review. Of these, 8 found low socioeconomic status to be a risk factor for increased CP prevalence. 3 studies detected statistically significant association even after controlling for birth weight and gestational age as variables. So evidence suggests that the effect of socioeconomic status on CP prevalence goes beyond that of the mediating factors like preterm or low birth weight. Perinatal causes of cerebral palsy includes hypoxic ischemic encephalopathy, birth trauma, prematurity, and multiple births. And postnatal causes include CNS infections, brain tumors, head injuries, vascular accidents in the postnatal period, and like strokes. And we know that the coagulopathy, underlying coagulopathies can be responsible for the postnatal strokes like protein C deficiency, protein S deficiency, factor V Leiden deficiency, and some other acute life-threatening events in the postnatal period can also give rise to cerebral palsy. Looking at this figure, we can see that the majority of the cases of the cerebral palsy are due to the antenatal causes. Perinatal causes include only 5 to 15% of the total cases of cerebral palsy, and the postnatal causes are about 10 to 20% only. So the major bulk of the cerebral palsy patients are from the antenatal causes. There are many ways to classify the cerebral palsy. We can classify it according to the neurological deficit, like pyramidal when the motor cortex is involved, or extrapyramidal when the basal ganglia or cerebellum is involved. Or we can classify it according to the movement involved, which is also called physiologic classification of cerebral palsy, like spastic cerebral palsy, which is the most common type of the cerebral palsy, dyskinetic cerebral palsy. It can further be divided into dystonic variety, which is more commonly seen in the term babies with history of hypoxic ischemic encephalopathy, or chorioarthritide type of the cerebral palsy, which is commonly seen in the babies who suffered blue ribbon encephalopathy or some other neurometabolic disorders. Ataxic variety is least common and seen in about 4 to 5% of the cases. And mixed type of the cerebral palsy, we all know, is commonly seen in the babies, term babies who suffered hypoxic ischemic insult or sometimes due to the underlying brain anomalies. Another way to classify cerebral palsy is according to the limbs involved, which we call topographic classification. So bilateral cerebral palsy, when both the sides of the body is involved, it can be quadriplegia, hemiplegia, or diplegia. Diplegia, is all know, is commonly seen in the preterm babies due to intraventricular hemorrhage or periventricular leukomalacia. Unilateral, when one side of the body is involved, it can be monoplegia or hemiplegia, commonly seen in the strokes. Diagnosis. Diagnosis of cerebral palsy is mainly clinical, based on a detailed, good history, and followed by a comprehensive physical examination and supported by MRI or brain imaging. I think we have heard in yesterday's webinar a lot of things about how to assess the cerebral palsy patients and how to detect the early clinical signs. Here I will summarize it in only few slides. At presentation, it is very important to obtain a detailed history, including perinatal, postnatal, and developmental history, paying attention to an event that might have been the cause of the birth-related injury or hypoxic ischemic insult to the brain or any postnatal brain injury. After taking a good history, it is important to perform a thorough examination, including the detailed neurological examination and also the development evaluation as necessary. It's very important to recognize the early motor features of the cerebral palsy, which may include unusual fidgety movements or other abnormalities of the movements. And yesterday, one of the co-speakers have talked, if you were attending the webinar yesterday, they have talked in detail how to pick up these abnormal movements. You also have to look for the asymmetry of the movements, which may indicate hemiplegia or monoplegia, and also the paucity of the movements. Persistence of primitive reflexes beyond the expected period is also very important clue in the diagnosis of CP, and abnormalities of the tone, which may include spasticity, dystonia, or hypotonia, again, give us a clue about the diagnosis. Abnormal motor development, delayed developmental milestones actually are one of the important clinical signs which bring the child to our clinics, either picked up by the parents themselves or by the general pediatrician or the general practitioners, and then referred to the pediatric neurologist or the neurodisability pediatrician for further evaluation. So this is one of the very characteristic feature of cerebral palsy. Feeding difficulties in the initial newborn period or initial postnatal period is actually seen in mostly in the quadriplegic, spastic quadriplegic patients. On subsequent visits, it's important to diagnose the cerebral palsy or to review the diagnosis of cerebral palsy by looking if the patient is following the expected pattern for cerebral palsy, taking into account that the signs and symptoms may change as the child grows. Every pediatrician should be aware of the red flags for disorders of other than CP. I'm not going to go in detail because one of the co-speakers will be speaking about the cerebral palsy mimics, but I would like to mention here that these are the red flags and all of us should be aware of them. Absence of a known risk factors for CP, family history of neurological condition, regression of the developmental milestones which point to the neurodegenerative disorders, and hypotonia associated with weakness which points to the lower motor neuron lesions like SMA, myopathies, or muscular dystrophies. Marked worsening during the periods of catabolism is an indication that this child may have an inborn error of metabolism, and development unexpected, seeing the unexpected focal neurological signs or MRI findings which do not match with the diagnosis of cerebral palsy or other red flags. The best clinical practice is to classify the extent of the disability, activity limitation, and participation in the live activities by two tools. And these are called gross motor function classification system and manual ability classification system. Gross motor classification system is actually a 5-level tool which classifies the degree of the disability, and also it focuses on the movements, on the sitting and walking of the child. So this is actually the gross motor function classification system. The level 1 is the least disability. There is no limitation in the walking. These child can walk normally, but probably they are slower than their peers. Level 2 gross motor GMFCS level 2 is actually a mild limitation in their mobility. They can walk unsupported on even surfaces, but on uneven surfaces, they may need support, or when they are going up and down the stairs, they may need support. GMFCS level 3 usually use handheld devices for walking, or for the longer distances, they may use the wheelchairs. Level 4 is usually wheelchair dependent. They may take 1 or 2 steps without support, but usually they are carried in wheelchairs, and when they are walking, they cannot they cannot stand without support, so they need support even in the walking frames. Level 5 is the severely disabled child who is totally dependent on caregivers. He cannot even hold their neck and support their tongue without support. Manual ability classification system is used by the occupational therapist usually, and it is also a 5-level classification system which classifies the hand movements, the participation in the daily activities of living, like playing, dressing, and eating. We all know that the management of cerebral palsy is multidisciplinary. Early recognition and early intervention is important to obtain a better prognosis and prevent complications. General pediatrician or neurodisability pediatrician is the key person who coordinates the care. And physiotherapists and occupational therapists are involved in almost every patient who has cerebral palsy. The other subspecialties, they are invited or they participate in the care only depending upon the patient's clinical condition and the associated comorbidities. As we have seen in the second half of the definition, that cerebral palsy is a motor disorder, but it has a lot of other comorbidities, and it is our duty that we have to screen for these comorbidities and treat them or refer them accordingly. So visual impairments is commonly seen in cerebral palsy children, and about 20% of the cases of CP have associated refractive errors, squints, or other visual impairments. Hearing impairment is seen in about 10% cases of cerebral palsy. Learning disability is seen in about 50% of the cases of cerebral palsy, and the extent or the severity of the learning disability actually depends upon the severity of the motor function. So if the child of gross motor function classification system 1 to 2 will have milder learning difficulties, while those who are from 3 to 5 may have a severe learning disability, and IQ may go down as low as less than 50. The other comorbidity includes epilepsy. One of our co-speakers will be talking about the epilepsy in cerebral palsy in detail, so I'm not going to go in detail of that. And the other comorbidities include very commonly recurrent wheezing, asthma, and recurrent aspiration pneumonia, which may be due to gastroesophageal reflux. So it is very important to look for the gastroesophageal reflux and evaluate the need of the fundoplication or gastrostomy. Drooling is also very commonly seen in quadriplegic patients. It can be treated by oral medications or by injection Botox in the salivary glands. Osteoporosis is seen in mostly bedridden, non-ambulant patients. It is important to evaluate their bone health and do the BMD as needed and refer them to the endocrine team for further management. Other comorbidities include pain, discomfort, and sleep disturbance. And this is very important. Pain is an important factor in the quality of life of the patient. To find the cause of the pain and treat it makes a lot of difference in the patient's well-being and improving his quality of life. So as a pediatrician or as a neurodisability pediatrician, whoever is looking after the cerebral palsy patient, it is our utmost duty to find the cause of the pain, discomfort, and sleep disturbance, and try to treat the treatable causes and to make the quality of life better. Constipation is also very commonly seen in non-ambulant and bedridden patients of CP. Recurrent urinary tract infections are commonly seen. The musculoskeletal problems which are associated with CP are mostly scoliosis, joint contractures, and hip dislocation. So in the next few slides, I will be talking about the surveillance of hip dislocation. It is important for the scoliosis, it is important to clinically screen the patient on every visit for the scoliosis. And if we see that clinically the scoliosis is present, then we can go ahead and do a spine X-ray. To prevent the scoliosis, we should provide them spinal support appropriately so that it do not worsen. And surgical intervention should be provided to all the children as needed. I will not go into detail of that. So coming to the Management of spasticity, Dr. Umar will be speaking about it, so I will not go into the details. Here I will say just that all children with spasticity should be referred to physiotherapists and occupational therapists, and successful treatment of spasticity lead to a better motor function, prevention of the complications, fixed contractures or deformities, and enhance the functional abilities and independence, and ultimately leads to improved quality of life. Management of dystonia is really very difficult in patients of cerebral palsy, very hard to control. I have noted many medications can be used. These are the list of the medications which is used in pediatric age group. I have noted that the patients who did not respond to baclofen and trihexyphenidyl, I have used gabapentin and they responded well. Coming to the hip surveillance for the hip dislocation is very important part of the management of cerebral palsy. The prime radiological measure for the hip surveillance is migration percentage. If the migration index is more than 30%, immediate referral to orthopedic surgeon is required. A hip is usually considered to be sublux if the migration is more than 33%. And hip surveillance depends upon the gross motor function classification system. The more disabled the child is, the more frequent hip dislocation surveillance he will require. So GMFCS level 1, we normally do the pelvic X-ray between 1 to 2 years of the age. However, if the patient doesn't present to you in this age, you can do it whenever he presents on the first visit. And then he should be reviewed at 3 years of the age. If he still has GMFCS level 1, no need to do a pelvic X-ray, just clinical assessment is enough. And similarly, he should be again reviewed at 5 years of the age, again assess the gross motor function classification system. If it is level 1, then no need to proceed to pelvic X-ray. However, if the level changes, then the surveillance will be according to the next level. And in between 2 and 4, more frequent hip surveillance is required. And if the migration percentage is more than 30%, as I said you earlier, the patient should be referred to orthopedic surgeons for intervention. However, if the migration percentage is less than 30%, but more than 50%, then 6 to 12 monthly surveillance is required till the age of 7 years. At 7 years, the surveillance can be temporarily stopped and can be renewed or reviewed, started again at pre-puberty level, because in this pre-puberty, the child will grow fast. And it should be continued till the skeletal maturity. And if at the skeletal maturity, the child is showing the signs of pelvic obliquity, leg length discrepancy, then the ongoing hip surveillance should be continued. And same is true for the level 5, but here it is more frequent. You don't stop it at 7 years of age, you continue it and just space it to yearly surveillance and continue it even beyond the skeletal maturity, because the chances of having hip dislocation is more in more disabled patients who are bedridden. So these are the Australian hip surveillance guidelines, and I use them actually for my reference. I found them very useful. So the take-home message is cerebral palsy, though it's a disorder of motor function, but it has a lot of associated comorbidities. And as a pediatrician, it is our duty of care to look for them, screen them, and treat them accordingly. There is no cure for CP, but timely diagnosis and early intervention can improve the quality of life. Appropriate therapy tailored to individual need helps expand physical and cognitive skills and abilities and improve the self-esteem and emotional well-being. Always talk to the families, listen to them, ask them about their individual needs, and establish a good relationship with the parents and the other family members. This helps to increase their compliance to your suggestions and your clinical recommendations. So need of the hour is to formulate a comprehensive national guidelines for the diagnosis of and management and surveillance of cerebral palsy. When I was looking for the prevalence rate in United Arab Emirates, I did not find any data. So I think this is the need of the time that we should start a cerebral palsy registry in the Emirates and to establish the cerebral palsy support group in the community, because we are lacking this in our community. And thank you very much. These are my references, and thank you.